As Laurin pointed out, my name is Chet Abresch. I'm the Executive Director at CityMatCH, and my partner in crime this morning is Dr. Laurin Kasehagen. Laurin is actually a CDC employee. She's assigned to CityMatCH as our MCH epidemiologist, senior even MCH epidemiologist.
I think that means more age than knowledge.
Is that right? Yeah. Laurin only kind of likes CityMatCH. She came to us, 6 years ago or so, and she's staying for what I say is forever. She's been a great help, and as you will see, I'm saying all of the easy stuff, and she's saying all of the really smart, hard stuff. So as the presentation goes on, feel free to raise your hand at any time, ask questions at any time. But by way of getting started, we wanted to talk to you a little bit about CityMatCH, just to make sure that we're all on the same page. I saw there was a number of hands for folks that are familiar with PPOR. Could you let me know if you're familiar with CityMatCH? Okay, so we've got a couple in the room. So CityMatCH is a national organization, and our members are health departments in large communities across the country. And within those public health departments, our member representative is the individual who has senior most accountability for maternal and child health outcomes. So here in Nashville, that person is Dr. Kim. Or in Memphis, that person is Calandra. And it is our role and mission in life to make those folks as successful as they can be at promoting the health of women, children, and families in their communities. And we do that through a variety of mechanisms, education, training. We have an annual conference. But one of the things that is really a hallmark is the translation of data and science to practice. And in fact, that's what PPOR is all about today. It's about the use of data to inform a community-wide process to make strategic decisions about where resources should be invested for programs and policies that are going to improve infant mortality. CityMatCH also focuses, we say we have 3 pillars. One of our other pillars is a focus on equity, issues of disparities and equity. As you'll also see today, Perinatal Periods of Risk is really at its core all about social justice. It's all about understanding why some folks within a community, some infants and some families might enjoy one set of outcomes but not all, and understanding how we can get there. And then the last thing that we focus on is building great maternal and child health leaders. So today we want to essentially do 3 things. We want to look at providing a general understanding of the perinatal periods of risk approach. We also want to describe its 6-stage community process. And then we want to provide some practical community-based examples of what that looks like. So these are the 3 things that we're setting out to do, and not necessarily in that order. We'll kind of flip it around. So let's start off here with the 6 stages of PPOR. If you've heard about PPOR, you may be most familiar with its analytic methods. And we're going to talk a lot about those methods today. But what you should know is that PPOR is more than an analytic process. Really what PPOR is a way to engage communities and empower communities so that the folks around the table that come together and look at those analyses are able to make decisions, and they're empowered to make the right choices about what should be done. So this process encompasses the 6 stages that we advocate be taken with PPOR. First phase 1, or stage 1, is all about assuring community and analytic readiness. So those are 2 things there. Number 1, the community piece is making sure that the right people from the community have been assembled. And not only that, making sure once they've come together that they all know their roles, they all know their responsibilities, that there's different assets that each of them bring to the table, and how can those best be employed. In addition to that, this group needs to make sure that they have the analytic readiness to be able to complete the aspects of PPOR that require that. Laurin will be talking more about that in just a little bit. Stage 2 is actually the conducting of the analysis. We'll focus a lot of our time and attention there today. Stage 3 is then looking at what came out of those analyses. You saw a great short presentation in it from Veronica in the last plenary, and saying, okay, well, given what we've seen in the data, where do we need to be focusing our attention? Is it on that maternal health box that she pointed out in the plenary? Or is there also some attention that needs to be paid to the infant care box? So it's really about coming up with high-level strategies about where you're going to target your efforts. Stage 4 then is either strengthening existing programs or launching new ones. So this is kind of drilling down one stage. You've selected the areas where you want to work, and now what are the programs that are going to take you successfully to improved maternal health? Or what are the programs that are going to take you successfully to improved infant care, such as safe sleep, which we heard a lot about as well. Stage 5, of course, is monitoring and evaluating your approach on those programs that you've implemented. And then stage 6 helps restart the process, reinvigorate the process by showing all of the stakeholders in the community that are there what's been accomplished throughout this cycle. So if you look at this, let me ask the group a question. If you look at this, what stands out to you, if anything?
Community involvement.
Mm-hmm. Community involvement, anything else? This is essentially just the essence of good public health practice, right? There's really nothing unique or special about these 6 stages. You've seen them probably in lots of different iterations or slightly different verbiage, but this really is about how to practice good evidence-based public health from beginning to end. So moving on to our next slide here. We've got the question, why is PPOR necessary? And the main point that we want to draw out here, of course, is because infant mortality is a complex issue. Infant mortality is a complex issue. It's rarely, if ever, one thing. And it exists within an ecological model here. It exists within a varied and complex environment. And then also you can see across the bottom that it exists within life course health development. So we understand that by the time that you get to pregnancy, the 9 months of prenatal care are likely too late in many cases to dramatically alter the outcome of that pregnancy. So we need to start long before, and we need to continue long after. It's influenced, it says there, by a lifetime of events and experiences. Next slide here. I said at the outset that PPOR is both a hallmark of CityMatCH because it translates data to practice, but I also indicated that it was a hallmark of CityMatCH because it really gets at the issues of equity and justice. So I've been at CityMatCH now for 10 years, and I still remember my first week on the job because in the office right next door to me there was a CDC assigned MCH epidemiologist by the name of Bill Sappenfield. And does anyone happen to know Bill in the room? So if you know Bill, you know that he's a legend in the field of MCH. He's one of the co-adapters along with Dr. Magda Peck of the PPOR process. And you also know on conference calls he's got a pretty booming voice. So even though his door was closed, I could hear him giving this presentation through one of our coworkers' phones. And what he said on this line was that at the heart of PPOR there is a question. And the question is this: if some in a community can enjoy a level of outcome that you see along that bottom row, why can't all? That's essentially what PPOR is. It asks a question of justice. And then it looks at that question from multifaceted angles to understand why. Why is it that not everybody is enjoying that level of outcome? And how can we empower the community to make change so that we can see that top line come closer to the bottom? This is a real county's data, correct? We call it urban county.
We call it urban county.
But it is
We're not supposed to disclose who it is, but
it is a real city, and Laurin and I know the place well.
yes, we do.
Yes, we do. We'll leave it at that.
And I've disclosed it often, inadvertently and explicitly.
So you see here again our 6 steps for PPOR that we went through. This time they're shown in more of the planning cycle. But the point on this slide is that PPOR is a complementary model. So if a community already has, for example, a FEMA review in place or Healthy Start in place or health assessments in place, PPOR doesn't compete with those things, but it overlays those things and can work quite well with them. If you think about it, CityMatCH has also done a lot of work in the area of femur. We've partnered with ACOG, where the National Fetal and Infant Mortality Review is housed, and we've adapted it to look at other perinatal morbidities. PPOR is a wonderful tool because it can be illustrative of some of the system failures that families experience. But what femur doesn't do is provide you with that population level look at the data around infant mortality. What PPOR doesn't do is provide you that in-depth look at a mother's experience and even the maternal interview that femur can give you. So together the two are stronger, and we would advocate that communities build towards the capacity of being able to do both. Look at the individual cases, mom's story, and look across the community at population level data. PPOR provides a framework that helps communities move from having data to using data. It prioritizes limited resources by allowing communities to see where they most need to target their efforts. And then it uses evidence to maximize impact. So what makes PPOR different than other analyses of infant mortality? We have three things here. Number one, its overall approach. It emphasizes community input and engagement. It has a standardized process for analyzing and reviewing fetal and infant data. And the method for using local data informs change. Second piece is that it's not only looking at infant mortality, but it incorporates a look at those fetal deaths as well. And this is important for reasons that Laurin will talk about later in the presentation. But as we know, sometimes those numbers of infant deaths and fetal deaths can be nearly equal. So it examines both of those in two dimensions.
Okay, so thanks for coming this morning. So, as Chad mentioned, we measure infant mortality and fetal mortality in two different dimensions. So the first dimension is birth weight. And so many of you are already familiar with different birth weight categories, but we have extremely low birth weight where we're less than 1,000 grams, very low birth weight between 1,000 and 1,500 grams, low birth weight between 1,500 and 2,500 grams, and then that which is normal birth weight, so anything above the 2,500 grams. The second dimension, if I can get this to move forward, there we go, is age at death. So we look at not only the period of from birth to up to 1 year past death, but we also look at those deaths that occur from 24 weeks gestation up to when they would have normally been born, so maybe 40 weeks gestation, okay? So why do we include fetal deaths? As Chad mentioned, most often what we see in communities is the number of fetal deaths are almost equal to the number of infant deaths in a community. So normally when we calculate infant mortality rates, we're only looking at those that died from birth up to 1 year. You're missing a huge amount of data, and you're missing a huge amount of the population information that can be informative. Plus, these are deaths that are really very important to individual families. A loss of a fetus is the same as the loss of an infant. These are really important deaths. And it can help us also better understand some of these underlying issues around what's going on in fetal and infant mortality. If we can't understand what's going on in infant mortality without understanding what's also going on during that gestational period. So PPOR is about using all of this information. So also, as Chad mentioned, CDC and CityMatCH adopted a World Health Organization model that was a lot more complex. So as you can see here, there are like these 16 boxes. Everything was divided up into these very finite, small little cells. That was way too complex. So what happened was we meshed them together into 4 large areas. And so birth weight and age at death were used to create these 4 periods of risk. So on the top, you see maternal health and prematurity. And along the bottom, you see maternal care, newborn care, and infant health. And each each of these boxes were named to suggest also the areas of prevention. And so here are the areas of prevention. So preconception health behaviors, prenatal care or perinatal care, high-risk obstetrical referrals, neonatal care, pediatric surgeries, sleep-related deaths, injuries, and so on. But let's look at an example of what one county did with their data. So we're going to talk about Urban County. We're going to use some older data, their 2000 to 2003 data. And their map, their PPOR map, looked like this. And they had 97 deaths in that 4-year period. In the maternal health and prematurity box, they had 48, 44, and 47 across the bottom. And one question that you might ask yourself is, are these low or high counts? How would we know? Anyone want to take a guess? Jennifer, you sat in. Chad! Jennifer, anyone want to take a guess? Okay.
We don't know what their birth rates were.
Exactly. And we don't, what is another thing we don't know? We don't know the size of the population, right? Okay. So we need to know how many pregnancies we had altogether. But because we're also looking at fetal deaths and live births, we know we don't have a good tracking system for pregnancies. Many women lose that pregnancy really early on and miscarry really early on, not even knowing that they miscarry. So our best measure is what we know from live births, but because we also want to track fetal deaths, the live births don't talk about fetal deaths. So we want to pick up the fetal death data, okay? So in this case, there were a little over 23,000 fetal deaths and live births. And then we started calculating rates using both the numerators and denominators from these boxes. And here's the calculation. So in this case, for maternal health and prematurity, we had 4.2 deaths for every 1,000 live births and fetal deaths. And here are the rates along the bottom. Anything stand out to you so far? Anything look high? Look interesting? Okay. So how do we find out about the deaths and how do we count them? So many of you know we've got a vital registry system. The vital registry system is going to capture live births and it's going to capture deaths. That's done fairly well. What isn't done very, very well are fetal deaths. Lots of differences, lots of different practices, recording practices. Every state is a bit different. And which deaths do we count? So we look at the mom who resides in the geographical area of preference. So when you're doing your PPOR analysis, you need to define what area are you looking at. So it could be a neighborhood, it could be a county, it could be a city, it could be the entire state. You also need to know when the birth occurred. So you're going to rely on your vital records to look at a specific time period. You may not want to do all 10 years. We're going to talk about some of the constraints of this. We may want to talk about looking at 2 or 3 years. You need to know when the baby died. You also need to know that there are some restrictions. So we're not very good about the data is inconsistent around the recording of deaths and kind of the grams at birth with gestational age, and the fetal deaths are not counted if they're under 500 grams or earlier than 24 weeks. So CityMatCH and CDC went through a pretty intensive analysis to look at where we started to get consistent data. So where was the reporting at a population level really good? And we found that those breakpoints were at 500 grams and at 24 weeks gestation. Some areas are really good about reporting everything and really good about looking at and tracking kind of gestational age. So they may go down to 16 weeks. They may go down to 20 weeks. This is where you really need to look at your systems and know where you start to get good, consistent data. But by and large, most places get good data at 500 grams in 24 weeks. And I will say that usually we let you calculate some of these because it gives you some experience in calculating. and because we have an hour today, we're not going to let you have that pleasure, so we didn't tell you to bring your calculators, and I know you all have them and you really want to use them, right? Yeah, right. So let's talk about prematurity and maternal health. Here we have a rate of 4.2, and again, you might be asking yourself, is this a good rate or is it a bad rate? And we don't know unless we have a measure of reference, some sort of benchmark to compare yourself to. So what we use in PPOR is often called a reference population or a reference group. And this is a population of moms that experience good outcomes. So they have low fetal and infant mortality rates at the population level, not necessarily at every individual level. So it's not every mom that has only extraordinary outcomes that are really great, and then you put them all together. We're talking at a population level. Can you get together a group of women that by and large have good outcomes? And we've done this in a number of different ways. Historically, what CityMatCH used was well-educated, white, non-Hispanic women who are at least age 19. That seemed to be a pretty good measure. In Louisiana, they felt that even though they want their mothers to achieve equitable rates of good outcomes, that they needed something as kind of like a stepwise kind of approach up to better outcomes. And so they picked well-educated African-American moms as one of their populations. So they had two reference groups, white educated and then black educated. We also have used sister cities. So that's another way that you could look at finding a reference group. But ultimately, this is something that the community decides. What is the best benchmark? What is it that we want to shoot for? Who is a reference population that is acceptable for the moms, particularly moms who are experiencing losses, to say that this is what we want to shoot for? And if they want to do a stepwise approach, these are all decisions that are really at both the public health department level and with the community that's invested in these outcomes. And again, it's really about achieving justice. So for Urban County, what they decided to use was 20 or more years of education, of age, 13 or more years of education. They were all non-Hispanic white women, and they were residents of the United States at the time of the baby's birth. The other thing about a reference population is that it needs to be at least 15% of the population in that area. So that's easy if you have a national reference group, but what if you have something smaller? So a state reference group or a county reference group. If you think about that, you need to have at least 15% of your population as part of that reference group. So, let me go back. So their total infant mortality rate is, fetal infant mortality rate is 5.7. So this is going to look different from the infant mortality rate because we've included the fetuses that have died. So it's going to be a little bit more. And it's just comprised of all, you just add up all the rates in the different boxes. So it's almost exactly like the infant mortality. We've just broken it down into 4 distinct periods, and we've added the fetal deaths. So for Urban County, they're on the far left, and you can see that their rates are a little bit higher than the reference group rates. And this is how we get it. So what we call the rates that are in the far right those are the excess rates, or the excess number of deaths per 1,000 live births and fetal deaths. For maternal health and prematurity, it's almost a twofold difference, right? You see a lot more. And this is how it looked like when we compared the white non-Hispanic rates to the black non-Hispanic rates in Urban County. The other thing that you can see is that you have differences in the denominator, right? So you have many more white births occurring to white non-Hispanic as compared to black. It's just the population is a lot smaller in this Urban County. They have about a 9 or 10% of the community is African American, and so you just don't see as many. Are they less important? No, it's not that they're less important. So by using different practices in math, you're going to be able to see an equitable way to compare the white and the black deaths and excesses. Okay, so you can see that there are some distinct differences. We're seeing a greater burden of mortality among the black non-Hispanic population, many more deaths in that very small birth weight, but all across the age range, and that's that blue box of prematurity and maternal health. So that's what's going along in the blue box. But you can also see something going on in the green box, and that's infant health. So that's a live birth, but then died between birth and 1 year of age. So there's something going on in at least two of these boxes. And this is just to show that we can also calculate the number of preventable deaths. This is another thing that the community has to decide for itself. Do you want to show rates? Do you want to show raw numbers? What is it that will engage the community in an effective way? And within the health department, you may talk about rates because that's something that everybody's familiar with and can grasp onto. But at the community level, when you go out to community stakeholder meetings, you'll have to decide and work with the community members to figure out what is the best way to show this data. What is the best way to talk about the data? Do you talk about it as empty strollers, empty classrooms? Do you talk about it as empty cribs? Or do you talk about it in terms of rates? So another way that we often express this difference between the rates and the excess mortality is we call it the gap. So a lot of times you'll just hear it referred to as the gap. And we also can use something, a very simple calculation to look at the percentage of excess mortality. And so here we know that two of the boxes, so prematurity and maternal health on the top, and then in the lower right-hand corner, infant health. These two areas of infant and fetal death contribute up to 70% in this community of all the deaths. So we know that that might be our low-hanging fruit, if you will, of where we need to focus some efforts.
That's 70% of the gap.
70% of all of the deaths, yeah, and the excess mortality, okay? So again, we've got a little bit of success, and we know that this county, although maternal care and newborn care are probably important, maybe where they want to concentrate some of their first efforts might be either on the top area or on the very bottom area. Another thing that you'll need to work out with your communities is that sometimes you need early successes to kind of get momentum and engagement. And so sometimes people want to work on the really hard one. Maternal health and prematurity, that's a hard one. There's a lot going on that we still don't understand, even in a scientific and clinical arena, about what contributes to really early prematurity and to what's going on in maternal health during this phase. Infant health is low-hanging fruit. There are things that are there that are evidence-based, that are doable, that we have really good programs around. And so sometimes people will focus on that just to get an early success and kind of get the community engaged. But it doesn't mean that one area is more important than the other. So there's more. I know that you're really excited about this. So you've calculated that whole calculation of the rates and getting the reference population together. That's considered phase one of the analysis. There's another phase of analysis. And so this is kind of, these are, as Chad mentioned, the two hallmarks of the whole PPOR approach. Is this is what people think that's what PPOR is. It's just the calculations, but it's not. Remember, it's part of the engagement and trying to figure out how to tell this story of numbers to community members that may not be so comfortable with numbers. So in this part of the analysis, what we are looking for are the probable causes that contribute to that excess mortality. We want to look at risk factors for those causes, and then we want to calculate or estimate the potential impact of those risk factors. So we're going to talk about how Urban County did their investigation in the infant in the infant health period of risk. And the procedure is pretty similar, but there are little twists for each of the different periods of risk. This one is much easier because we have better data around it. Some of the other periods of risk, we don't have such good data, and we may not have such good ways of knowing what's happening. So we're going to use this one as an example. So there are a lot of common causes of death in the infant health period of risk, and here are some of them. So SIDS or SUIDs, drowning, car accidents, infections, assault, congenital anomalies. And the first step was to figure out in Urban County what was causing their excess mortality. So what they did is use the ICD10 codes from the death certificate, and this is just a partial list of those codes for Urban County. And if you look along, as you're looking at the number of deaths that are in that middle column, you see 1, 1, 1, 1, but then you get down to the bottom and you see 15. So that's a good indicator that there may be something going on with sleep and suffocation in this community. So they looked at their mortality rates of all these different mechanisms along the bottom, and they compared themselves to the reference group, which is in red, and Urban County's in the blue. And what's one of the first things you notice? We're way above the reference group, right, in sleep-related deaths. So again, they felt like they had a really great success. They eliminated a number of the contributing causes to their to death during the infant health period. Those that were injuries, congenital anomalies, some of those, even though they're important, they aren't the bulk of the deaths. The bulk of the deaths were sleep-related. So that's what they're going to focus on. So they compared their sleep and reference groups and started looking at the risk factors that relate to sleep-related deaths. They looked at sleep position. They looked at maternal smoking, prematurity. They looked at the bedding that might have been with the child in the crib. They looked at co-sleeping, crib availability, parental substance use, and death scene investigations. So for smoking, they went to the birth certificate and found that in their community, they had a higher smoking rate than their reference group.
Is that a smoking rate in the home, or is that a smoking rate just of the mother?
That is just the mother. So, and that's a really great point, because you may need to look at what that smoking rate is in the household overall. So there could be other caregivers, there could be other family members. It's not just the mom. So particularly for those older, the 3 or 4 month SIDS, definitely. You want to look at that household exposure. Yes, ma'am?
Does this include smoking during the prenatal period or only?
This was smoking, whether they were a smoker at the time of birth. So it will pick up that prenatal, and it kind of records that. And I don't know exactly how Carol did calculate this, who is our analyst. So I don't know if she picked up and combined both the pre and what we know about postpartum. As you know, for birth certificate, you're going to pick up the prenatal and kind of before. You're going to pick up that kind of history, and maybe if they were smoking during, but you're not going to be able to pick up from the birth certificate postpartum smoking. And Tennessee is fortunate because you have PRAMS data now. And you can use your PRAMS data to look at, before they became pregnant, the last 3 months of pregnancy, and now you can look at postpartum smoking. So you'll be able to pick that up on your PRAMS data. And I would encourage you to use all the data that you can. So the other thing that they learned was that over 70% of the babies in Urban County were actually put to sleep on their backs. And Urban County is that red bar to the far right. And you can kind of look at some of the other states that have PRAMS, and they look very much like some of the states that are doing really well. So in Urban County, back to sleep wasn't one of their contributing causes so much as other factors. But what were those other factors? So they talked to the child abuse investigator teams, and they learned that couches, blankets, the recliners, and a lot of parental drug use were indicated in several of the different SIDS death cases. They also did a local survey of their obstetricians and gynecologists and learned that many of the doctors were not discussing safe sleep practices with their moms prior to delivery, and most were not even aware that there were smoking cessation services available to moms. So there are some other indicators here that maybe we've got parents doing the right thing by putting the baby on the back, but maybe they've got a lot of bedding or other things in the cribs. There's maybe some co-sleeping, and there's definitely some smoking that's going on. So using their PPOR findings, the FEMUR team there in Urban County focused on sleep-related deaths for 6 months and looked at primarily those deaths and learned that also moms reported a lack of social support and having a lot of stress. And all of those moms reported consistently some of these things. So, Chad, tell us why FEMUR is so important to be used together with PPOR in our communities. So, the next step for Urban County was to estimate that impact of the risk factors and look at the potential impact of the interventions around sleep-related deaths. So we used population attributable risk, a really great statistical method that I'm sure all of you are going to go home and look up and use right away, right? Yeah. And they looked at the different types of factors that could be modifiable. They looked at whether there were evidence-based interventions that already existed. And they also looked at what the assets in their community were, what type of capacity they had, and what kind of commitment there were from moms in the community, as well as providers, insurance companies, the entire breadth and scope of all of those community partners, what kind of investment they had. So they weighed their evidence and sought more information. And so their initial action steps, early on, they had a Sleep on Back campaign. They broadened that to a safe sleep message so that they could focus on it's more than just being on the back. It's being on, it's being in its own bed. The baby's in their own bed. They're in their own bed without a lot of toys, a lot of blankets. They're not co-sleeping. They could be in the room with the parents, but not, and so not all the way across the house in another room by themselves. They also started working with doctors about smoking cessation services for pregnant women. And I also know that they had a really large campaign within the hospital system there to talk about safe sleep, because what they reported, and this is, I think Veronica Gunn mentioned that this morning, is that what people saw in the hospital rooms was very different than what they were expected to do when they went home. And so there needed to be this consistent messaging from providers all the way to family members, all the way to the primary caregiver. And then they started partnering with a group that was already working on maternal mental health issues to start addressing some of the stress and isolation that a lot of these mothers felt that they were having to deal with all on their own. So we felt like Urban County had won a lot of valuable prizes. Their investment was focused, and their time was focused. They found a lot of answers, and they were able to design a number of action steps that were appropriate to what they had initially envisioned, which was it's not just back to sleep, it's a safe sleep environment. And this is what's been happening with Urban County over time. So you can see from the mid-1990s, where they first started looking at their infant mortality rate and decided that that infant mortality rate was not acceptable. What you're seeing here are the combined rates, and you're not really able to see the gap that exists between white mothers and black mothers in our community. It has gone down also appreciably among black mothers. So as you can see, the overall fetal infant mortality rate has dropped 2.5 percentage points. Overall, you've seen a continued decrease in infant mortality or in the infant health period of risk. Without doing anything at all, we've also seen a drop in that pink box of maternal care. We don't really know why that happened, but it's happened. It could be system level issues that we aren't really aware of. And maternal health and prematurity has stayed pretty constant. That's because I think there haven't been really good mechanisms in place for that community or any community to really start to address prematurity and that maternal health. Until we get some sustained long-term work around interconception care and preconception care, we're not really going to see very many differences. So, why doesn't everyone use PPOR? Well, you need at least 60 fetal and infant deaths for each population studied. You can combine multiple years, but we often don't recommend that you go over a 5 years period of time, mainly because you can get system changes there and not really understand why that's contributing to changes in your death rate or medical practices. And you can even have these at hospital level protocols that have changed practice in the hospitals. So that's just something to keep in mind. And then when you get to a phase 2 analysis, you're going to require more data, so more deaths, in order to make better sense of it. You need a clearly defined study population. Sometimes with smaller communities, we find that you can't get enough, and it's a good problem to have. If you can't get enough deaths, it's a good problem to have. But sometimes all the deaths are occurring in one portion of your population, so African Americans perhaps, and you have no deaths or very few deaths in the white population. It doesn't mean that you shouldn't study it. What you should do is do something different. Go to FEMUR, use a FEMUR approach, and bypass PPOR. It's where PPOR may not help you very much. And then you need access and use of 3 vital records data files. You need the fetal deaths, infant deaths linked to birth records, and live births. And then you need somebody who can handle that data. And that's what everybody calls the data geek, but I have termed the data diva. And so everybody needs a data diva. So why use PPOR? And we want to have full strollers. We don't want empty strollers. So thanks for your time today. Appreciate it.